Welcome everyone to this very exciting Friday evening lecture. Thank you for joining us. I know Friday evenings are a hot time, so we're excited to have you here with us today talking about GI oncology and what changes Monday morning. So we're just gonna jump right in. We've got a lot of stuff to talk about today. So I'm gonna go around the virtual room and we'll do some quick introductions so you can get to know your panelists a little bit. So we'll start with Dr. Aparna Parikh.
Hi, I'm Aparna Parikh. I'm a GI oncologist at the Massachusetts General Hospital Cancer Center. I primarily see patients with colorectal cancer and pancreatic cancer, do a lot of work in liquid biopsy work and ctDNA and things. So I'm really thrilled to be here to discuss a lot of the ASCO GI updates with all of my esteemed colleagues here.
Great, and next we have Dr. Cathy Eng.
Hi, Dr. Cathy Eng from Vanderbilt Ingram Cancer Center, David H. Johnson, endowed chair in surgical and medical oncology, and co-director and co-leader for the GI program at Vanderbilt, Young Adult Cancers Program.
Next, we have Dr. May Cho.
Hi, my name is May Cho. I'm a GI oncologist at UC Irvine. My interest in drug discovery and clinical trials.
Great. And then finally, we've got Dr. Arturo Loaiza-Bonilla.
Perfectly said. Thank you so much, hi everyone, and I appreciate the time today on a Friday evening to join us. The Enterprise Director of Research and also the GI Program Director at Cancer Treatment Centers of America. I'm currently located in Philadelphia as my practice.
Great, and I'll do my quick brief introduction. So my name is Dr. Shikha Jain. I am a GI oncologist at the University of Illinois Cancer Center. I obviously subspecialize in GI oncology, and then I have a special focus in neuroendocrine tumors. So with that, let's dive right in. There are so many trials and so much exciting data to discuss. We're gonna start today with discussing some colorectal cancer trials. So the way we're going to set this up today, guys, is we're going to talk about these things kind of as if we'd be talking in a doctor's lounge and kind of discussing how we manage patients and how ASCO GI has really made us think harder about how we're going to treat certain patients. If you have questions, please send them in. I will try to get to all of your questions as we get through this hour-and-a-half session. So we're going to start off with, like I said, colorectal cancer. We're going to start with Keynote 177. So for those of you who don't remember, because I know there's a lot, we throw out a lot of trials with a lot of numbers. So I'm going to give you a brief summary of what Keynote 177 talked about. It was a study looking at pembrolizumab versus chemotherapy for MSI-high, MMR, mismatch repair deficient metastatic colorectal cancer. And it was a phase 3 study. And what they looked at was patients, again, either they received pembrolizumab or they got chemotherapy. In this trial, they found that first-line therapy with pembro doubled the progression-free survival when compared with chemo, and it cut the incidence of severe toxicities by about 2/3. So the median progression-free survival in the pembro group was 16.5 months, and in the chemo group was 8.2 months. We're still waiting for the overall survival results. And 48% of patients who got pembrolizumab were still alive and free of progressive disease at 2 years versus 19% in the chemo group. There was also a difference in the objective response rate of 43.8% versus 33.1%. And with that, I want to toss it to our panelists to start the discussion. So again, this trial was looking at IO therapy with pembrolizumab versus chemo in our MSI-high patient population, which is really a new and exciting way to hopefully start treating our colorectal cancer patients. So Dr. Eng, I'd love to hear your thoughts on this trial and kind of where you think we go from here.
Well, I think that, obviously for our newly diagnosed treatment naive patient that tested for MSI-high and ends up being MSI-high. And I think it's really important just to add on that, I just gave a lecture, for instance, at University of Toronto yesterday. So in Canada, they do not do standard MSI testing on all patients up front. And they're also not doing NGS on all newly diagnosed patients up front. So they're trying to get this approved. And I was quite fascinated about this. And for us, this is critical because we test all of our patients, right, for MSI status. And because of these kind of trials. So as you mentioned, the results with single agent pembrolizumab for newly diagnosed metastatic patients is favorable in regards to progression-free survival. and it was tolerated extremely well. And for the 1/3 plus patients that were on the control arm with standard chemotherapy, when they went on to pembrolizumab, they also benefited as well. So I think it demonstrates that we need to continue to use molecular analysis to help our patients. For all newly diagnosed patients, this is the way to go. A lot of us are intrigued as well by Checkmate 142, which is looking at nivolumab and ipilimumab in treatment-naive patients. Granted, that's a phase 2 study, but I think this really, it makes it more provocative. And maybe we can start looking, and I think we're all thinking about this, looking at neoadjuvant therapy for both early stage colon and possibly early stage rectal. I know May and I actually published, thanks to her work, she published a case series in JNCCN regarding her experience. And I think I've also been doing it off protocol. I'm sure some of you have as well. And ECOG is supporting Kristen Siomber's study for MSI high rectal coming up. So it's exciting. It's an exciting time. But I do have to say that I did meet my first patient that had been on Pembro for almost 2+ years, came to me as a second opinion consultation recently. And I just had him scoped a couple of days ago. I think it was last Friday or Thursday. He has now developed a new primary, although his first primary has now fibrosed. So this is quite interesting. So, you know, now what do? Do I do NEO? Do I put him on another, do I do standard chemo? Do I find another trial? So I think we're gonna see more and more of these kind of stories. So.
And I think to your, maybe I can add, you know, I think what's sort of exciting about, you know, I think one thing with the trial, but also to your point, Cathy, about what do you do with people that have benefited for so long? You know, one thing that came up with the Keynote study is there were actually, the rate of progression, though, primary refractory patients was higher in the IO group, right? So there was still about 1/3 of patients that didn't benefit from, you know, immunotherapy that just aren't responders. And, you know, are there biomarkers and tools, perhaps things like liquid biopsies and ctDNA and things that can help us sort out early on who the non-progressors are? And then, you know, again, this is all like case level data right now, so kind of not ready for prime time, but what do you do with someone who hadn't had another primary but was on treatment for 2 years? Can you follow their kind of ctDNA kinetics over time? And if, you know, if it looks like you can't see these in the blood anymore, can you stop therapy? You know, and I think in the melanoma world, they're sort of sorting that out too, as patients are responding longer and longer. Yeah, can you actually stop treatment, and when do you stop, and what are the biomarkers that can help us figure that out? So, you know, it was really, really exciting, but I think to try to figure out who those primary refractories are, and on the flip side, to figure out who those long responders are who may not need exposure to therapy anymore, is also going to be really interesting. Or like escalation, right? The Nivo-Ipi data. So if someone's not responding to kind of monotherapy, can you add the CTLA-4 and kind of salvage and rescue responses? So I think even within this like 5% subset of metastatic disease, like a lot of different ways that we can go.
I'm so glad you actually brought up that KM issue in the very beginning of the KM curves where there's that overlap. Because I think I didn't mention it because we don't have a great answer. I find it really fascinating because I think we're trying to figure that out. But I mean, obviously looking forward to the final data. And I would love to see what May and Arturo think about that. What do they think about that odd, you know, splay in the KM curves?
Yeah, so you know this the GI ASCO 21, there's like updated data about PFS2, right. And you know, but it's not really a PFS2 per se. It's from the randomization to the second progression, right? And then as Mike Overman pointed out, it would be nice to know from the first progression to the second progression. You know, there's some kind of theoretical data that IO may sensitize the chemotherapy down the line. So of those who progress on that 30% of the people, when they're on chemo, they stay longer. I have a few patients who like straight through progress on Pembro and then on FOLFIRI for like 2 years and complete response. So I think that actual PFS2 data might be very useful for us as well.
I definitely don't have any of those patients, May. I'm very intrigued.
Yeah, no, that's very interesting. And I think that, I mean, I think all of you highlighted the first thing, which is understand those subset of populations that respond or not to treatment. We are facing already with a situation that many patients are on the genotype. So even things that are basic as MSI high, it doesn't get tested, which to me is like, what? It's like anathema to everything we're doing. I think a call for that so we can have a good baseline and select patients appropriately. And then over time, once the patient develops progression, it would be nice to have a repeat, maybe through a liquid biopsy or whatnot, to see what changed, what led to the progression of the disease or lack of response. And as Dr. Parikh was mentioning earlier, maybe assessing for those patients who have responded for so long. I have a patient that
seems like we lost Arturo.
Arturo froze. All right, while we're waiting for him to unfreeze, there was actually a question from the audience of, do we ever? Oh, he's back. Sorry, Arturo, you froze. Could you give us the last 30 seconds again?
Yeah, can you hear me now?
Yeah.
Okay. Yeah, so what I was saying is that using this ctDNA for also response in terms of having, I don't know if, should we stop? The patient is very nervous, so maybe having, negative DNA on the serum, we may be able to make that call. I think right now there's a lot of opportunities in the testing side that we can explore. And now there's combinations of chemotherapy and IO, which maybe will be the next step, kind of following the examples that we're seeing in other diseases such as lung cancer. So a lot of excitement on that area from my perspective, of course.
And anal cancer, by the way, that's a phase 3 trial.
So we have a question from the audience about, do we ever see MMR status change from biopsy of primary and metastatic lesions? And actually, Cathy, I have a question for you too that's kind of complementary to that. When you said this patient got a second primary, was the second primary the same MSS status as the first diagnosis?
So I do not know yet, because oddly enough, because his first primary had such a great response that it had fibrosed. But now it's narrowed the anal rectal canal. And so the new primary is at the sigmoid region. So they had to use a pediatric scope. So it's limiting our abilities currently of getting an adequate biopsy. Ironically enough, he's also developed some new mediastinal adenopathy, which is, I just happened to send him off for a biopsy because I was concerned about lymphoma before I found out about this second primary. So I'm going to be testing the lymph node biopsy, the core biopsies from the lymph nodes coming up this week, actually. It'll be interesting.
Yeah, and I think the question is a fantastic question about changing of MSI status over time. And I think what we're seeing is we can use some of these tools like liquid biopsies, not only for TMB. There was another poster actually, presented from the trial, the Durva-Tremi trial from the Canadian group, and they actually looked at like plasma TMB compared to tissue TMB, and granted responses weren't great in that study, but they showed that like the plasma TMB score, changed over time, and perhaps that is a better marker too of true TMB than the tissue. And with MSI status too, I think Dr. Pashtun Kasi had a paper that came out a few months ago looking at, again, response to checkpoint inhibition, not only using kind of variant allele fraction in the blood, but looking at MSI status in the plasma and sort of seeing the MSI status sort of clear over time. So I think there are markers now for us to be able to do this in a less invasive way. But to the question, I don't think we have like great data because we're not like serially biopsying all these patients, but these larger cohorts are developing where we're following people in the blood over time.
We were just as an aside, we were just talking about clinical trial design for SWOG for a junior faculty member, and we all want the biopsies, right? Because that really is the best way to evaluate these patients. But funding, insurance coverage, so many barriers, honestly, that I wish we could get more assistance with.
And patients like, willingness to do serial biopsies too, right?
So the next question, really good question from the audience is in MSI high colon cancer, is there a difference in benefit depending on RAS or BRAF mutation status based on sidedness, anything else? So kind of talking about these MSI high patients and then looking at other mutations and looking at the sidedness. do you take that into consideration when you're deciding your treatment plan and looking at, IO therapy versus something else?
I mean, I'm happy to start the conversation. I think Aparna and most of you already know. I mean, I know that they had looked at the germline versus the somatic mutation, so your hypermethylators versus your typical Lynch patients, and they didn't notice any difference in the original Checkmate data in regards to those patients and outcomes. In regards to sidedness, that has not, I think the numbers are so small to begin with, and then to tease out sidedness, but I don't recall anything specific in regards to sidedness from any of the studies thus far, specifically. Aparna, I can't recall anything specific for sidedness for MSI high.
No, I can't. There was some, maybe like maybe KRAS status potentially, ERAS mutation, little, but not much. And then, but I think what might be just good for the audience to sort of know is that there's that 30% overlap with BRAF mutations, right? And so kind of the overlap between BRAF and MSI is there. And I think for now I think most of us sort of treat the the immunotherapy sort of trumps, BRAF right now, but I think there's now combination IO BRAF studies too, which is a whole nother topic that Dr. Eng just had an excellent article on as well. So, but I think that's pretty nuanced, but I think we'll see kind of even IO targeted combinations coming forward independent of the MSI, but there is a 30% overlap with MSI and BRAF.
Yeah, I think it's so important that we need to test these patients because we're not only looking for MSI, but we're also looking right now for the opportunity for BRAF, testing and potential treatment in the second line or third line and beyond. And many of these tumors tend to be favoring the right side, which we all know have worse prognosis. So if you have a BRAF mutated patient, typically those patients don't do as well with chemo, even if we use, the FOLFOXIRI Bev current treatment that we have. So having that extra layer is really helpful. I just had a patient of mine, she's in her, mid 80s, came in a wheelchair, just ready for go to hospice. And we drew a liquid biopsy, found that she had BRAF mutation too, but she had, MSI high. And she's been on pembrolizumab single agent already. And just the data just came out and she had a near complete response now, she went back to normal. And so it's a great story just to kind of tell you the importance of doing the testing, because now a patient that otherwise was going on hospice, now she just got her COVID vaccine and, looking forward. So that's great.
That's a great story. I do want to emphasize for those that aren't very familiar, just remember the BRAF mutation is really important to be tested when differentiating germline versus somatic. And so that's why we keep on bringing up the BRAF mutation. And so, just to keep that in mind, because I think people sometimes forget how important that testing is. And also how, I guess, I haven't had a home run yet with TMB, but obviously we are aware that TMB is approved also for an indication for immune checkpoint inhibition. So
I don't know if any of us, I don't know, has anyone yet? I think the
so those POE and POD mutations, they are like ultra mutated one, right? Yeah. So they have response, and then I have reported the case. It was MSS, but then it was TMB was like 28, and then the patient responded to the immunotherapy. And also within MSI high, we published the I think 40 patient study. It showed that higher TMB has more response rate over lower TMB. So yeah, but still a small data.
Yeah, I think 28 is the magic number for I think an abstract that was presented at ASCO GI on the TMB side. That's particularly for the liquid biopsy side, because we always had this question is, can we rely on, with the new test coming now that check for blood TMB, is it equivalent to the tissue one? Exactly. And at least now we have some early data that potentially we have a better cutoff number now with those. And every tumor is different, at least my perspective, at least not colon cancer TMB of 10 is much different than a pancreas cancer TMB of 10, right? So just for the audience as well to realize that every cancer patient is different, because even for those things as TMB can have differences in responses in microenvironment.
So to answer somebody has another question. What is the concordance of TTMB and BTMB?
Okay,
I'm sorry, the concordance between
T?
Biopsy and
TMB, I think that's the question, right?
blood and tissue.
That's what I'm thinking the B and the T stand for.
Yeah.
So tissue and blood, TMB.
What are we talking?
I think I'd have to look. I'd have to pull up I don't know the numbers from the off the top of my head from this the Durva-Tremi study, but what they did show was that the plasma TMB was a better predictor of response than the tissue TMB for the efficacy. That was MSS patients and like a small number of responders. So, but I can't remember the exact concordance.
It was Jonathan Laurie's trial. I know that just because we worked together for a little bit. But like you said, small numbers, I think, because some of us were talking about it as part of the chat room for ASCO GI, and I'd like to see it validated.
Yeah.
But intriguing nonetheless.
So the question for this particular trial that we started off talking about, the Keynote 177. So what changes Monday morning? So are we going to be doing pembrolizumab first line in our MSI high metastatic colorectal cancer patients?
Yes.
Sounds like that's the consensus. All right.
With one small caveat, I'm curious to see what your guys' thoughts are too. So I think, that 30, if someone has, I mean, again, the MSI group, so someone I had a patient come up with this who had a very, very, very bulky disease burden, right? And this wasn't FOLFOXIRI, right? This is FOLFOX or FOLFIRI, so doublet chemotherapy and high disease burden, MSI, and you're still like young patient and categorically unresectable, but maybe eventually. So I was nervous, right? Because I didn't want to be in that 30% miss of non-responders and this young patient who I kind of felt like I had one shot on gold. So I, ended up doing the FOLFOXIRI Bev because we know the response rates are kind of astronomical there too. So like, I think for the far majority of patients, yes, but just maybe there is that one patient that you're maybe resection, bulky disease burden, like you're worried if you don't get that right, the next time you check your bilirubin is going to be like 15 and you're like hosed. So
yeah, I agree.
That's my only me.
The only one. I mean, obviously each patient.
Yes, of course.
For each patient. And I understand where you're coming from and where you want to be aggressive and see where that may lead you because of the degree of high tumor burden. I mean, I've also done Nivo-Ipi combo off protocol for a patient. Yep. And now he's in a CR. So
awesome. That's awesome. Yeah.
That's great. All right, so moving on to the next colorectal cancer study, we're going to talk about TASCO-1. So talking about TASCO, it was just to remind everybody, phase 2 study evaluating trifluridine, tripyrasil plus Bev versus capecitabine and Bev in the first line. This was for unresectable metastatic colorectal cancer patients who are not eligible for intensive therapy. And it was a one-to-one randomization with the primary endpoint looking at progression-free survival. They found that for the main analysis for progression-free survival, they found a delta 1.41 different of months in median progression-free survival and a delta of 4.64 months for median overall survival between the trifluridine group and the capecitabine group. And they found that these results were consistent on survival probability looking at different time points. And then they also looked at, so the overall survival was one of the secondary endpoints, and they found a difference of 22.31 months in the trifluridine group versus 17.67 months in the capecitabine groups. So the thoughts for the next step on that are hopefully the phase 3 Solstice study will give us a little bit more information. And I'm gonna throw this to Arturo for the beginning of this discussion on the TASCO trial.
I mean, this is a very interesting concept because we have been using, the trifluridine tripyrasil drug always in the latest stage of our patients, almost like third line and beyond. And having the opportunity to see if there's any signal compared to capecitabine has always been up to the test. So I feel that the TASCO data is an encouraging, signal. However, the only challenge I see is that the difference is not that dramatic, right? So in terms of outcomes, so the jury's still out in if it's going to change our practice for Monday, right? So that's the question I have for the rest of the panel as well, and what they think as well. In my perspective, I think it's very promising, but I would like to see further trials in a larger, follow up and bigger groups, so I can really know if I should start making those changes.
Can I just chime in real quick? I just want to make sure that the audience is aware TASCO is really for those kind of suboptimal patients, right? So patients that are older or with poor PS. So it's a great option for patients. And so that was one very unique aspect about this trial. I think that it's, if there's somebody, and obviously, once again, we're talking about the fact that many of us individualize our care for our patients. So when I have a patient with poor PS that may be elderly, I think it's reasonable to do tasks with Bev or 5FU or Bev, and then sometimes I just escalate to the next cycle. If they tolerate it well, then I'll add another agent, right? I'll add oxaliplatin or I'll add irinotecan, depending upon what the patient is willing to sacrifice, whether it be neuropathy or alopecia. But I think this trial just provides additional information. I agree that we obviously need to see the solstice data. But I was surprised the delta for PFS was very small. But and maybe I shouldn't be surprised. Maybe this is what is expected from this drug, which is a unique, modified, updated version of how we need to move forward with some of our oral agents, but not as I guess not as cytotoxic as FOLFOX or FOLFIRI.
Mm-hmm.
Also, I mean, I think it's also, like you said, Kathy, about escalation later on, but there's, phase 2 data for Lonsurf Bev, from Lancet for later lines too, with also sort of intriguing and sort of supports, Bev beyond progression, as well too. So like, how do you think about that if you're sort of like thinking about, and maybe your poor PS patient, you're not necessarily thinking about 3rd and 4th lines.
That's what I was going to say.
So like it might be like a mute point, but sort of a lot of our colorectal cancer patients, you are able to sort of think about that. Even in the marginal PS patients, you're able to get some dosing in of, doublet for a lot of patients. So I think it's very sort of subjective what that entry criteria is, and there's how you think about it in the whole like journey of patients in CRC when you're sort of thinking about what next.
So, since that Lancet and then Derma studies, I have been given back with the Lonsurf together. And so TASCO kind of confirmed that, that's better PFS and better OS. So I have been using that more in the later line setting. I mean, I think that this trial is so timely, especially for COVID, right? In the era, that you don't want to put on the 5FU plan and coming back in 2 days. Yeah. So that's really timely. And this is European study, and then for US, I really put older patient on capecitabine, with the CKD and all these things. And I have to say, test 1 or 2 is a lot tolerable than capecitabine, even if we don't look at the efficacy data, in terms of just toxicity alone. So that's another tool for us,
But we do have to be careful for the audience, right? That we know this drug causes myelosuppression with neutropenia.
Yeah.
So even though I agree with you completely, I'm not a huge fan of using Xeloda in an elderly patient population, especially with reduced creatinine clearance. But we do need to be cautious still about Lonsurf and the risk of neutropenia. And in all fairness, off protocol, I actually do a different schedule. I don't do Monday through Friday, 2 weeks in a row. I'll do 1 week on and 1 week off. That way the risk of neutropenia is less.
So there actually was
my personal practice.
Well, there was actually a question, Dr. Eng, specifically asking for Lonsurf dosing. Is day 1 through 5 every 14 weeks a superior schedule to the FDA-approved schedule in terms of efficacy, toxicity, and what are you using this schedule? So you've shared your schedule. Is anyone else using a different Lonsurf dosing than what's written by the FDA?
I actually use what Kathy does too. So yeah.
I do the FDA dosing, and then I give the Neupogen if needed in the second cycle.
Yeah, so because our specialty pharmacy is very specific and want to prevent Mayer denial, so I just follow with that. And maybe as move forward, then we make adjustments. And I have a few patients on Cathy's protocol. We can call it now. So,
Cathy's protocol.
Cathy, I'm going to call it Cathy's protocol in my clinic now from now on.
Well, I think it's probably like, it's how it sort of goes with these sort of things. It's like when you first get used to using them, it's sort of like when we were using Rego and you're like, oh, like no one can do this. And then you started using half dose and escalating, but then you realize it's a crap drug anyway. So like not.
Let's be a little bit more positive now.
I know. No, but I think so like the FDA, like labels our guidance, but as you get kind of more accustomed to treating, you play around with dosing, but, and in the metastatic setting, I just haven't been using as much with the growth factor. I try to like figure, but it's so like, it's a little bit of the art, maybe a little bit of the fun.
I want to hear an interesting story is that I actually spoke to the company probably 3 years ago. So they never thought at that time about doing 1 week on, 1 week off. And it also made a lot of sense, right? Because you're doing 5 days in a row, so why not just always start on Monday, right? Monday, Friday, and then alternate. But they never thought about it because you guys don't know because you're still quite young. But that drug has been around when I think I was just starting out as an attending, and they had completed multiple schedules to optimize the dosing. So when we finally got the schedule, they're like, we're not doing anything else.
So someone's asking for a clarification. When you say 1 week on, 1 week off, are you using day 1 through 5 or day 1 through 7?
No, I do. Sorry, that's a great question. The drug is only meant to be given for 5, usually to make compliance or adherence better. I always start on a Monday, so I'll do Monday through Friday, and then the next week off, and then Monday through Friday, the 3rd week. And one cycle is still 4 weeks to me.
Great. So another question, kind of throwing back to our discussion from earlier on immunotherapy and chemotherapy and MSI status. So somebody asked, do you consider using chemo immunotherapy as first line for your MSI high metastatic colorectal cancer patients?
But there's one trial going on, right? Like the Atezo plus FOLFOX, and then it used to be 3 Alliance trial. I think I have something, the name, I'm forgetting the name.
I forget the name, but it's the Alliance trial.
Yeah. So, I mean, only on protocol, I do that.
So for this trial that we just discussed, so what changes Monday morning? So for those patients who have a borderline to poor performance status, who probably won't tolerate the other therapies, we're thinking we would likely recommend the trifluridine Bev combination, and we use now the Lonsurf dosing that Cathy uses for certain patient populations. That sound like a reasonable what changes Monday morning plan?
Yeah, and also in that line, instead of just using the Lonsurf alone, throw in the Bev as a continuation of the VEGF.
Perfect. All right, so we would be remiss if we talked about GI, ASCO, and colorectal cancer and did not touch on what was discussed on ctDNA. So I'm just going to give some highlights on what was discussed, and then I'll open up the floor to you guys. So some of the abstracts discussed serial analysis of ctDNA, looking at it in the postoperative setting, and they found you can identify patients with stage with non-metastatic colorectal cancer who are at higher risk for recurrence. That was a prospective study that looked at that. There was a study looking at the utility of ctDNA detection to identify molecular residual disease after resection and predict the disease recurrence. And then there was also discussion on ctDNA and comparing it to CEA and looking to see which one would be more accurate and more effective for assessing patients who've recurred and recurrence-free survival. So there was a lot of interesting stuff coming out about ctDNA, and that's always a hot topic. I get asked it by any of my patients who do any Google searches on updates in cancer care. So I'd love to hear you guys' thoughts on what you think about circulating ctDNA. Do you use it often in your practice? Is it something that you're ordering on all of your patients, or is it still something that you want to wait and see? And I'm going to start this one with Dr. Parikh.
Yeah, so we could have a whole hour and a half just on ctDNA, but I think I'll briefly mention the studies. I think as an overview, just to sort of set the stage a little bit, I think more and more data over the years, I think we're all starting to feel very, very comfortable that ctDNA is indeed predictive of recurrence or prognostic. I think the big question remains is it actually predictive of kind of response to therapy? And I think with some of the data we were seeing here at GI ASCO, we were actually starting to see again, data like we've seen before, actually being able to clear ctDNA and the benefit of adjuvant chemotherapy. So there are sort of two studies. The one was a group, the Danish group from Denmark and Spain. It was a 265 patient prospective observational study, and they looked at postoperative ctDNA in around 215-ish patients, I think maybe a couple more. And around 9% of these patients had ctDNA detectable after surgery. And of those 9%, 75% of patients relapsed, which is like in stark contrast to the 13% of patients that relapsed in the negative group. But what's interesting was in the 5 patients that were positive and did not recur post-op. So these are patients that were positive post-operatively, ended up not recurring. All of those patients received adjuvant therapy. So small number of patients, but suggest again that adjuvant therapy can indeed cure patients. They also followed patients serially, and only 3% of the patients that were negative ended up recurring, but basically all the patients who were positive at some point in time recurred. Not surprisingly, it was better than CEA. They also reported like a lead time bias, which lead time of around 8 months from ctDNA to radiographic progression. But we have to kind of keep the lead time bias sort of in mind because you're not necessarily doing the ctDNA at the same time in the scans. And so you're not scanning and ctDNAing at the same time all the time. So it's really is a little bit tricky to kind of actually sort out what the real lead time is. And, it didn't really answer the question, but I think from a lot of the other ctDNA studies, it probably sort of tells us that around 50% of, patients, as we know, can be cured with, conventional chemo. There was another study from the UK group, the TRACK study, and that was also stage 2 and 3. The other one was included stage 1 patients, and it had very similar results, kind of 42% relapse versus 8%, relapse. So I think what we're seeing is, it definitely is predictive of recurrence, but what can you do about it? It varies by stage. And I can sort of tell you where I'm using it and being very careful of where I'm using it. There's lots of trials going on. I think one particular case where I'm using it is in stage 2. So, right now we use clinical pathologic criteria in stage 2 cancers to make a decision about whether to give adjuvant chemotherapy or not. And there's some, some patients that are a little, you're kind of debating what risk factor is, driving here. Should I give it? Should I not give it? And you're wavering. And I certainly would not de-escalate if I was planning on giving chemotherapy. But if there's someone you were debating on or someone who was a little reticent to give chemotherapy and they were positive, I would be swayed to give chemo. And we can have a whole nother discussion about which chemo to give then and how long. And then, in stage 3, there is a stage 2A, the Cobra trial that's, Van Morris and all are doing for 2A patients. Lots of escalation and de-escalation studies in stage 3. And the stage 3 in some elderly patients who I'm a little bit nervous about chemo and you're not giving Doxali anyway, and you're not sure, maybe you can use that as a tool. And then where I think it could be also interesting, again, on trial, not yet out of trial, but I'm using it out of curiosity, is in the oligo-met sort of setting. We have data from the Europeans as well as Japanese in terms of kind of perioperative or adjuvant therapy in the oligo-met setting that hasn't really lent itself to overall survival benefits, but it's sort of standard of care because PFS, DFS is all better. So that's sort of standard of care, but can we sort of better start to select the patients who would actually benefit? So not, definitely trying to put people on study, and using it in particular cases to make clinical decisions.
Yeah, and I think those are excellent points as always. Something that for the audience as well to realize is that currently we have two different approaches to ctDNA in this setting. So one is the tumor-informed approach, which is basically when you take the surgical pathology sample and send it for ultra deep sequencing, and they clear the germline and they check for different, the top 16 mutations. That's one panel. And there's another one, which is the one, for example, the COBRA study that we mentioned, which is looking for the not only for the DNA sequencing, but we're looking for epigenetic signatures. And they do the methylome and all that stuff, and that doesn't typically require tissue to send out. So the jury's still out on which approach works the same way or better. We don't know yet. So just when you're reading that and when you're ready to make that decision on the right patient to test, just be aware of those two nuances, so you know exactly what the requirements are, particularly when you're talking to your pathologist. This is a special test that you have to get them acquainted. I can tell from personal experience at CTCA, we have the bespoke and we have COBRA because we're NRG members. So we had to figure it out with the pathologist which one to talk to and when to send those specific tests. So something to highlight as part of this. But I think those use cases that are pretty much on mark of what I typically do. And much more relevant now in the era of the IDEA collaboration study, when we are now shortening our period of time of chemotherapy, for example, with K-POX for 3 months in most patients. So it may be helpful now to figure out when we should try to, escalate or figure out what's the best next step. And there's some trials now running for that purpose.
I just want to chime in and make sure that we're very clear also for the audience, because one patient came into my clinic, handed me a box and said, my outside doctor said I should get this done. I fully agree with both of you. I definitely want patients to do this while on a clinical trial, if possible. There are trials for stage 2, as you mentioned, and for stage 3. There'll be another trial coming from Chris Liu and Arvind Dasari for stage 3 coming up. But for stage 4, patients receiving palliative chemotherapy that are surgically unresectable, I want to remind everyone what Aparna said. It is not predictive of chemotherapy response yet. It is definitely helpful in the setting of resected disease, and I agree with the oligometastatic setting, because I've actually been utilizing it myself in that setting if I'm not able to put the patient on a protocol. But I want to make sure, I think, because it is out there in many blog groups and in many patient advocacy groups that circulating tumor DNA is going to provide you the answer for everything, and that is not the case. If you are a stage 4 patient with surgically unresectable disease, we do not know the role and how to utilize it in that setting in response to chemotherapy. And keep in mind, obviously, there's a third of patients that won't have an elevated CEA to begin with, so I understand in that setting. But don't forget, we have to send it off to get the results, and that usually takes time as well. So if you're a stage 4 patient, if you're not feeling well, we're going to know, we're going to evaluate you in clinic, we're probably going to do your CAT scan sooner. So don't put all your eggs in one basket and presume circulating tumor DNA is the answer to everything for the stage 4 patient with surgically unresectable disease. So I want to emphasize that.
Perfect. So we are about halfway through our hour and a half. So there's one more, there's 1.5 audience questions that I think are important to address, and then we'll move on to gastric and G-Junction and and gastroesophageal cancers. So the question that it came from the audience was actually 2 people asked questions that kind of can be merged together. How long after surgery do you check ctDNA? And in a stage 3 patient, especially if they're N1, are you comfortable in not giving adjuvant chemo if ctDNA is negative? So
it's a really good question. I can take it. So we are, I think, to what we were talking about before with the different approaches, when you're starting to look at the ctDNA data, it's going to be really important to look at the time that the ctDNA is checked. So what is conventionally happening when you look at some of the data that's being published is people are reporting out kind of the sensitivity at 30 days, because that's a good time where the ctDNA half-life is really short and surgical healing and things has happened. And so your background of normal cell-free DNA is a little bit lower. So it's a good time in terms of checking it. The problem is what we're seeing is the sensitivities around that time point aren't fantastic, right? So I think with both kind of tumor-informed approaches and tumor-uninformed approaches, we're sort of hovering around kind of only 50-ish% sensitivity there. So I would absolutely not ever de-escalate care for like a node-positive patient based on that time point. I think what is happening and what I think will warrants further investigation and study is as you start to follow people serially, sensitivity goes up. And so people that are initially negative, you may catch them later on that's positive. But we're not doing trials yet. We're saying, okay, like if someone's positive 6 months or even like 8 months or a year later, can we intervene at that point? We just don't know that yet, right? So I think we'll see that over time, and maybe clinical trials will, be informative in that space if you can eradicate microscopic disease over time. But right now, when it matters to us is in that window, kind of 6 to 8 weeks when we want to start adjuvant therapy. And to the node positive question, we're not at all at sensitivities yet where I would feel comfortable de-escalating. I don't know if anyone disagrees, but.
I think everyone agrees with you on that one, Dr. Parikh. And then the other question was, how long after surgery should ctDNA get checked? I don't know if you covered that. Does anybody have an answer for that? Aparna, you want to take that too?
Yeah, I think we're just saying, I think conventional right now, about a month after is where we're checking it. Yep.
Sorry, I missed that. All right, so now we're moving to another part of the GI tract. We're going to move on to G-Junction, gastric cancer, all of that fun area of the body. So I'm going to start by bringing up a trial that I really like the name of, and I think it's really innovative and very interesting. So that's why we're going to start there. So this is the FIGHT trial looking at FGFR2 overexpression, FGFR2 expression, which we see often overexpressed in gastric cancer cases. About 60% of gastric cancer patients cases have overexpression of FGFR2. So we know that is associated with a higher T stage, typically more likely to have lymph node mets and more advanced stage, and often have a poor prognosis. So this study that we're going to talk about, this FIGHT trial, was looking at a humanized IgG1 monoclonal antibody that inhibited the binding to this FGFR2, and talking about kind of whether this improved progression-free survival and overall survival, which it seemed like there were pretty good results with a progression-free survival benefit of 10.2 months versus 7.3 months. But there was the concern that there was some increase in side effects, so things such as corneal events and stomatitis. So let's start with Dr. Cho. Dr. Cho, can you lead us in the discussion on this FIGHT trial and what we should take away from it?
Sure. So, as you mentioned, this FGFR overexpression or gene amplification, one thing I really like about the trial design is that, this is IC or ctDNA, right? Both of them are like very quick. IC take like 2 or 3 days, ctDNA takes 7 days. We have some cholangio trial that need NGS, which take like, 3 weeks, right? And on top of that, they allow the 1 dose of 4 files so that we will not delay people who are already obstructed, right? And then, the data look good. So anyone who have either overexpression or gene amplification, the PFS all come up, PFS increased to 2 months. And then you can see, like, if it is more than 5%, PFS increased to 3 months. If it is more than 10%, its PFS increased to 7 months. So it's very reassuring that we're like targeting it. And then they screen like 900 patients. It's 30% of them are positive, which is also great for our patients. So I'm very excited about the trial, and like you mentioned, like 25% of the patient got cornea, toxicity, and we have some other trial that's FGFR involves some cornea toxicity. If we can intervene early on with the eye drop and steroid drop, maybe hopefully that would decrease the toxicity. So I am very excited. I hope that we understand that it's only phase 2 study. I hope that we somehow, like, FDA would get some sort of preliminary approval, and I think it's a very good data to use it in practice.
Great. So it sounds like for what changes Monday morning for this one, the hope is that it may not change it this Monday, but maybe in a couple of months we'll see a Monday where we see the change and we get this drug approved. I think that would be the way we will interpret this data for now, with cautious optimism. Perfect. So next, again, IO therapy is the hot topic. I feel it's been the hot topic ever since I started my fellowship, which was several years ago now. So a long time ago, IOs became very popular, and probably for the last 20 years, but in the last several decades, we've seen huge jumps in IO therapy outside of GI cancers. And now we're finally seeing, I think, some movement in the gastric world and the G-Junction world. And it's exciting, some of the data that's coming out. So I'd like to start the IO section of this disease process by talking about adjuvant therapy. So we'll talk about Checkmate 577 first, looking at adjuvant nivo in resected esophageal or GE-junction cancers after neoadjuvant chemo-RT. So this Checkmate 577 study looked at stage 2 and 3 patients, and it looked at nivo versus placebo in the adjuvant setting. And they looked at a primary endpoint of disease-free survival. So this particular study concluded that it was the first study that's really shown that adjuvant therapy showed statistically significant and clinically meaningful improvement in disease-free survival versus placebo in these patients who'd been resected after they received neoadjuvant chemo-RT. So they found a 31% reduction in the risk of recurrence of death and a doubling in the median disease-free survival. And they found that this benefit in the disease-free survival was actually across multiple pre-specified groups, and they didn't really see a reduction in quality of life. So I think this is a pretty impressive study. And so I'd love to hear your thoughts on this one and really where we're going to go from here, because this is, I think, one of the first times we've seen some really impressive results when it's talking about immunotherapy in the adjuvant setting for this disease. So how about, I know, Arturo, we lost you for a few minutes there, but now that you're back, can I throw this question to you, and how do you feel about this study?
Yeah, no, absolutely. Well, we live in the age of Zoom when, things happen. But yeah, I think it's exciting data for me, because I had been waiting to see if there's anything in the adjuvant setting that actually led to some meaningful outcomes in our patients. There's been a gazillion clinical trials trying to overcome that issue, and we have not seen anything so far. So this is very promising. I think the major point now is to figure out which subset of patients benefit the most from these approaches. That we don't know if is TMB involved, is MSI, is a microenvironment combination, is it PD-L1 positivity to some extent making a difference, and as we know that's still to be determined. So I think is very encouraging now that we have that option. The question to me now is, what do we do now if the patient presents with progression? And is there a timeline for us to use immune checkpoint inhibitors at some point in the future if we already expose the patient to IO? So I'm sure there will be some studies coming our way in that perspective, but that will be probably the first question that I had in top of my head. But I think it's encouraging, and hopefully we can lead to better outcomes to what we know already. It's an extra option for the armamentarium of our patients. We use a lot of perioperative treatments for your gastric and gastroesophageal cancer, but having an IO option as well, I think, is helpful.
This study is very strong benefit. Across all tumor type, right? Regardless of PD-1, regardless of adeno or histology, I think this will get approved, and we all will be using them. So I guess the question really is, if the FDA gonna stick to, one part trial. The trial is you have to have pathologic, residual disease, right? Like, T or N, right? So that's a trial. So the question is, what if patients got the complete PET response? Can they also get it, right? That's number one. Number two, what if these some of the patients who can't do sulfectomy, can they still get cold-to-cold adjuvant therapy, right? So I think those are the two questions. But the data is very strong that I hope that we will get it approved pretty soon.
I think it'll be, I'm waiting for you to talk about the metastatic frontline setting, because then what if you progress? What are we going to be like colon if you progress within, you got your adjuvant IO? Or is it going to be like colon if you progress within 1 year, then that means you're refractory? And then what do you do now for frontline? Because you're going to be talking about another trial. I'm sure Shikha's going to be discussing with the very positive results too with IO, which actually, unfortunately, has changed all this clinical trial designs that were also pending. So
I think it'll be interesting too to see, because as you know, May was saying, this is sort of all subgroups too. And I think what we'll probably see for the first line, I think what the FDA will probably end up approving, and we can talk about the trial, is probably like CPS 5 or higher, right, for the combination too. So it'll be interesting to see how all these like subgroups and the different settings end up playing out. But I think probably in the first line it'll end up being CPS 5 is, I think, what people are expecting.
Mm-hmm.
Well, and I have to say, as a GI oncologist for years, I've seen my colleagues who treat renal cell and melanoma and lung cancer do all these exciting positive trials that come out with all these great results for IO therapy. So I have to say, I get excited every time I see a GI cancer study that actually is positive, and we're going to be discussing several of them. So I would say, to Cathy's point, it's a good problem to have. I think that we're at a point now where we can say, well, if you do an IO in the adjuvant therapy, in the adjuvant setting, are you going to be able to give it in the metastatic setting as well? I think that's something 10 years ago I never would have thought we'd be saying in a lot of these malignancies. So I think it's really, really exciting. We had a question, did this adjuvant study include G-Junction tumors too, or just esophageal? So I'll throw that over to whoever wants to answer that.
I think it was CWOT 1 and 2. I'm sure, like, we always consider CWOT 3 as more of a gastric. So that was my understanding.
It was stage 2 and 3, but it did include G-Junction.
Perfect. All right, so we're going to now move on to the metastatic, the more advanced setting. So we're going to talk about Keynote 590 next. So this is looking at patients with advanced esophageal cancer. This was a phase 3 trial, Keynote 590, looking at pembrolizumab plus chemo versus just chemo as first-line therapy in patients with advanced esophageal cancer. So again, these are locally advanced, unresectable, or metastatic esophageal adenocarcinoma, or ESCC, or advanced metastatic, e.g. esophageal gastric junction type 1 adeno-CA in the first line. Sorry, that was a mouthful there. And we were looking at pembro plus chemo versus just chemo. And this study actually found that pembro plus chemo versus chemo, they found a statistically significant and clinically meaningful improvement in overall survival, progression-free survival, and overall response rate. So this again was Keynote 590. So I'm going to throw this one to, I feel like I'm trying to mix it up and call on each of you equally. So Arturo, I don't think I've called on you in a while. So how would you feel about starting the discussion on Keynote 590?
Yeah, no, actually, yeah, and just to clarify from the prior one, yes, they included G-Junction. So yeah, I just confirmed a second ago. But yeah, for this trial, I think once again calls the question and follows up on what Cathy and I were mentioning, is like, now that we see data on patients actually responding to adjuvant IO, the next question is, should we use it in the metastatic setting as well in combination with chemo for better outcomes? And the signal is suggesting that that's something meaningful, and that's something that we should start to consider. So this clinical trial is following, once again, something positive that we don't see often in this, this disease type where there's a lot of unmet need, where instead of using IO or chemo, we're combining those drugs with a decent safety profile. We're already used to managing these diseases with supportive care and whatnot, but having the chance that the patient is able to tolerate those regimens and that we are getting some benefit, I think is highly encouraging. The question to me now is, once again, next line of treatment. So we used to say, if the patient has a CPS score of more than 10, we can try pembro in second line, and in third line, we can use it if it has 1%. Well, now we use everything, all the weapons at the beginning. is this going to pan out something that we are going to get the best mileage if we actually start the patient on the combination with chemo IO versus using sequential approaches down the line? So that's kind of like my open question, but no doubt that this is encouraging data from my perspective.
This trial, I mean, at least for now, is the IO naive, right? So, the thought is that it has to be all IO naive patients. And then based on what we know about at least single agent IO is we can't code to code re-challenge it, right? So I think that once we get first line in, and if they progress on it, the chance of them responding to the IO alone would be very almost a zero chance, right? So, as you know, like the esophageal gastric, they're very morbid, and then dropout rate is very high, right? For colorectal cancer, we can get like 90% of the patient going to the second line. But for esophageal and gastric, it's like 50% of them drop out going to the second line. So it would be nice to just go all upfront in a first line setting, So I think the question is, the data show that it's show the improvement even in all comer patient, but it's more significant in CPS score more than 10, right? So I guess that's where the question is where we can use it. It would be very selective to CPS 10, or like can we just use it in all patients?
I think they also update. I think the nice thing too, we also saw the quality of life update that they did from, so that they first reported this at ESMO, and I mean, not really surprising, but they showed, the addition of Pembro, didn't have a detriment in quality of life too. So I think that's, important when we're thinking about, like May said, these like kind of patients are sicker, have a harder time. And so we care a lot, and not that we don't care, about quality of life for all patients, but I think for these particularly fragile patients to, want to be very cognizant of how we're impacting quality of life with our therapies.
I have a question though. Since my training, I have never used a 5U6 for esophagus. I've been using FOLFOX. So will you guys be doing FOLFOX and Q6 week Pembro, even though this study is 5U6 for the panel?
Yes, FOLFOX.
I think we all, learned that we all, get to a same concoctions of the oxaliplatin combination with 5FU, even though there's like 20. So I think I'm on the same boat. So
I agree. Before we move on to the next trial, I want to ask somebody threw in a question throwing back to the FIGHT trial again. So someone asked, is the FGFR mutation or alteration that's seen that they're discussing in the FIGHT trial, is that the same one that you see in cholangiocarcinoma and bladder cancer?
Cholangio is more of a fusion protein, right? Like for cholangio, it's a fusion. The one on the FIGHT is the overexpression.
Okay, thank you for that. So now we will move on to the next. We're getting great questions from the audience. Please feel free to keep asking questions as we go through. We've got about 30 minutes left, and we're going to try to get through everything, and I'm going to try to get to everyone's questions. So please feel free to use the question function freely. All right, so the next study we're going to talk about is we're going to be talking about advanced gastric cancer, G-Junction cancer, and esophageal adeno-CA, talking about the Checkmate 649 study. So this one looked at nivo plus chemo versus chemo in the first line for these advanced gastric cancers, G-Junction cancers, and esophageal adeno-CA. Patients either received nivo-ipi, or they the second arm was nivo-Zelox or nivo-FOLFOX, and the third arm was just Zelox or FOLFOX. And the primary endpoints, again, for this study were overall survival and progression-free survival. And then they looked at the CPS, different levels of CPS, greater than 5, greater than 1. Looking at overall survival for patients in the nivo-ipi arm, they found that it was 14.4 months, and in the chemo arm was 11.1 months. The overall survival for patients with all PD-L1 statuses was 13.8 months versus 11.6 months. Progression-free survival they reported was 7.7 months versus 6.0 months. They found that the duration of response was about 9.5 months for the nivo chemo arm versus 7 months for the chemo arm. They also found that there was a higher overall response rate for the patients who are getting Nivo and chemo. So this study basically concluded that Nivo they concluded that it's the first PD-1 inhibitor to demonstrate a superior overall survival and progression-free survival in combination with chemo versus chemo alone in previously untreated patients with advanced gastric carcinoma, G-Junction carcinoma, and esophageal adenocarcinoma. They found that overall survival was improved in all tumors. They found that in especially patients who had a PD-L1 CPS greater than 5, there was a statistically significant improvement in progression-free survival. And then there's also this, so basically they concluded that Nivo chemo is a potential new first-line therapy for these types of patients. So I'm going to start with Dr. Parikh on this one. What are your thoughts on this trial?
Yeah, so I think this is where we'll start to see the label for the 5+ higher patients. And what we were talking about, I think it's really important to, and I think we're going to talk about this, the ATTRACTION study too, which was an Asian population where we also saw, a pretty significant PFS benefit too. And so I think for the, since ESMO, basically these two trials really were representing a paradigm shift for these treatments with advanced stage disease. So, really breaking through that 1-year OS mark for patients with the PD-L1 CPS score of greater than 5 is sort of a home run. So this is sort of, I think, will be very much practice changing. If not already, I think we're getting approvals off label still, but I think we'll see the approval coming soon.
Anyone else have anything to add to that excellent summary?
I would just probably remind everyone these were all HER2 negative trials that are being discussed, the Checkmate and the ATTRACTION.
Right.
And we can jump right. Oh, go ahead, Arturo. Sorry.
Yeah, no, and I think that's an excellent point because now we have a new FDA approved drug for HER2 positive, actually approved in the second line setting, even though the study was done in third line, but there was a gap in between first and third. So it made sense for the FDA for approval in the second line setting with the after trastuzumab. So this is all new data that is emerging, and we're learning more from that too. And I think the Destiny trial was also presented recently, which shows kind of those results as well.
And just for everyone, the drug that he's talking about is deruxtecan.
Mm-hmm.
So that's the HER2 refractory patient population that's already approved in breast and just got approved in gastric.
Mm-hmm. And it's having some very exciting colon data too. So I think we'll see that coming in colon. And I think maybe another just reminder, I think for the audience, right? This was metastatic gastric G-Junction and esophageal adenodes, even though the primary population was like 70% in the trial were gastric, but included is esophageal adenodes as well as G-Junctions.
And yeah, so that it would be, I mean, for me, it would be nice to have all CPS approved. I know that the primary endpoint was CPS more than 5, right? But then we still see the data in all patients, even in CPS more than 1. So, and the other question is, what if the FGFR2 is approved and then this, Nivo is approved? How would you kind of choose? That's also one of the discussions that come up.
Well, the FGFR though, I mean, we still got a way to go, I have to say. So I'm not exactly sure if we can think that far ahead, right? Because it's still early in development.
Yeah, but I think maybe to your, like the point of like, we're going to start seeing these biomarker subsets that have targeted therapies, and then like how eventually do we start sequencing targets with IO when it works, and if targets work. So lots of ifs.
Yeah, the biomarkers. Whichever biomarker is more expressed is the one we probably favor. So higher receiving wins over expression of the GFR and whatnot. So.
But wouldn't it be great though to have, have so many options like HCC, right? So you have to think about sequencing. I mean, that's unheard of in upper GI.
Yeah. It was in HCC until recently, right? It's like awesome. All right. It's like when I can even say now, being young, like when I was in training, we only had
Exactly.
sorafenib.
Exactly. I mean, the IO advances that we've seen in GI cancers in the last, 5 years have been really astounding. We have a great question, which I don't know who wants to take this one. Please summarize the results in treatment-naive stage 4 gastric CA. When do you do chemo alone, chemo nivo, chemo pembro? So that goes kind of to the a little bit of the sequencing question, but more, who do you decide to give for treatment-naive stage 4 gastric CAs? Who do you decide to give just chemo? Who do you decide to give chemo plus nivo? And who do you decide to give chemo plus pembro?
I can take that. I mean, I think for gastric, our positive data is with the nivo. You know, we have seen our heartbreaking Keynote 062 data, right? So if you're purely talking about gastric, we just have to focus on nivo, right? So then we can come down to chemo or chemo plus nivo, right? Well, it will all depends on how the FDA will approve. This data showed that CPS score, the primary endpoint is CPS score more than 5. So if FDA approves CPS score more than 5, so you'll look at the PA1 CPS score. If it is more than 5, you will do chemo plus nivo. If it is below 5, then you'll just do chemo alone. Unless FDA approved based on like all comma benefited, that regardless of any CPS score, then nivo is approved, then everyone should get chemo nivo.
So I think that's a good place to transition to the next study, which is talking about the ATTRACTION study, which again was in Japan, Korea, and Taiwan. And this study looked at nivo plus chemo versus chemo alone in previously untreated advanced or recurrent gastric or G-Junction cancers. And so these patients were allowed to have neoadjuvant or adjuvant chemo, and they got nivo plus SOX or CAPOX, or just SOX or CAPOX. So it was, again, nivo plus chemo or chemo alone. And they looked at primary endpoints of progression-free survival and overall survival. And they found there was a 1-year progression-free survival of 45.4% in the immunotherapy group versus 30.6% in the chemo group, with an overall survival that wasn't significantly different of 17.45 months versus 17.15 months. So they concluded that nivo plus chemo had a significant progression-free survival improvement, but not an overall survival improvement. But they did see superior response and a longer response duration. So a couple of people referenced this study earlier. How do you take this data and then kind of synthesize it with the data we have from the Checkmate 649 study? And would this change the way you treat your patients next week?
I mean, I can point out, like, I think 2 important differences. I think Cathy already mentioned it was, Asian, and then the primary endpoints were designed for all comers, right? Not just the CPS, rather than, so not meeting a specific CPS threshold population. And I think, the OS, when you look at the study, there were a lot of patients that had subsequent post-trial therapy too. So I think that does confound the OS there. So I it doesn't really change that. I see this sort of as like a huge win for this patient population.
Great.
Yeah, I totally agree.
How difficult it is to, particularly in gastric cancer, to put all the populations together, because we know by the old data that we have on the Avogast and like freezing the password, etc., when we know that different populations of patients have different responses to the interventions that we have, and that reflects on diversity of the data that we're seeing. So as Dr. Parikh was mentioning, I wholeheartedly agree that it just gives us the nuance to understand different trial designs and the impact they have in potential outcomes, and how we have to be careful about, what's the next line, checking for PFS 1 and 2, and how that can really translate into our interpretation of those studies. But I think that it doesn't take anything away from the data that we just discussed a few minutes ago. I think it's equally as meaningful. It's just different populations.
I actually brought this up with Mike Gibson, who's the vice chair for GI Task Force, and he's one of my colleagues. And I said, these trials, basically, it's very similar designs, how do you determine, you know, what exactly was the real difference here? Because there's increased PFS, there's increased OS in the Asian patient population. He said, he admitted it. He just said it's very, very difficult to tease out. And I guess, you know, this goes back to how hard it is to design clinical trials and how hard it is to get drugs FDA approved or EMA approved based upon where the trial was conducted. But, you know, this was compelling. I mean, their PFS was high, their OS is very high. Many of them went on to second-line therapy. And so I think that, you know, what happens Monday morning, I think we all know that we would probably all agree that this is appropriate to use in this setting with IO therapy, but the subtle differences, I'll be very interested to learn more moving forward, because these trials are really compelling, but very, very different in regards to outcomes.
So I have to say, I'm very thankful for Checkmate, because if we only have attrition data, I have to fight with PR to PR for like, okay, because there's no OS difference, that I'm not gonna approve it. I am so tired of that thing. So I'm very thankful for the Checkmate data.
I would agree. I don't think any of us like talking to insurance companies.
I was going to say, I bet we could do an entire panel on peer-to-peer and our challenges peer-to-peers. So in the last 15 minutes that we have, we're going to try to cover 2 of the pancreatic trials. So I'll briefly discuss the Polo Trial. So the Polo Trial was looking at, in pancreatic cancer patients, maintenance olaparib for germline BRCA mutated metastatic pancreatic cancer patients. They looked at overall survival from maintenance of olaparib for patients who had germline BRCA mutated metastatic pancreatic cancer. And they found that the hazard ratio for overall survival was in favor of maintenance olaparib in patients with this germline BRCA mutation. And they found that metastatic pancreatic cancer patients whose disease didn't progress during this time, but they didn't really see a huge statistically significant difference in this trial. So I'm really curious, Dr. Cho, with this Polo trial, kind of to hear your thoughts on whether you think that in this patient population, this germline BRCA mutated pancreatic cancer patient population, do you think that olaparib is a reasonable option to utilize for maintenance therapy in these patients, or no?
So, you know, I guess 2 things that I kind of take away from this trial is that the BRCA mutated patient, they do better, you know, and they respond to the cisplatin therapy. So that's a great thing for the pancreatic cancer patient, right? And then the other thing is, you know, for the patient, having that like a chemo break, the quality of time, it makes such a difference. I have a patients who were able to travel, you know, have a daughter wedding. So I guess if you look back on your deathbed, that's what they value, right? The quality of time that they have within the period they were diagnosed. So I think this, even though we don't see the overall survival data that much of a difference, I think that the PFS difference is very meaningful for the patients like pancreatic cancer patients.
Great. I 100%, you know, agree. I think some of the patients had really long, durable responses to. You can get the PARP, you know, you can come up with the PARP schedule. Even though PARP has side effects too, you can come up with the dosing that makes sense for patients. And I think, like May said, the chemo-free interval for those patients that were benefiting are really long, and you have some significant durability. So I think though OS didn't, you know, meet, I still think there's very much still a role for a certain amount of patients. And I think also in the trial, you know, like a quarter of the patients in the placebo arm ended up getting PARP anyway too. So
yeah, I mean, to me it was a disappointment to some extent, because I was really hopeful that the maturity of the data will show me a survival advantage, but we didn't see it. Still, I had patients who are on, you know, olaparib still and on the maintenance phase and doing great. And the thing is, I never had the chance with my patients before. I had some patients that, you know, we gave them the best we could with FOLFIRINOX, but then they started developing neuropathy, and the quality of life was terrible. And if we continue treatment, and moving on to gemcitabine and nab-paclitaxel wasn't really the best option, because they can also induce neuropathy, right? So if we can give them something, I mean, we ended up doing maintenance with 5-FU or 5-FU irinotecan combinations. That was a common before the Polo data. So now having a biomarker, I'm targeting something. Is not that I'm not doing anything meaningful. And we know that, the homologous recombination pathway has some impact on that. Hopefully we can maybe find new options. I think there's some trials now coming using IO in combination with PARP inhibitors that may give us the extra edge to improve the outcomes that we have not seen on the current data. But still, I have some patients that had direct benefit that I didn't have the chance before. So I still consider it as a viable option for the few available therapeutic options we have for patients with pancreas cancer.
I'm glad you mentioned about the IO PARP. My former attending, Vincent Chen, is leading the SWOT trial, IO with PARP. So we're excited about that trial.
The phase 3 trial that should be opening any day.
So the final trial we're going to talk about today in pancreatic cancer is the Alliance trial, looking at pre-op FOLFIRINOX or FOLFIRINOX radiation for borderline resectable pancreatic patients. And I thought these results were really interesting. So looking at the chemo alone or chemo RT for these resectable patients, they didn't find an improvement in overall survival in these patients who got radiation along with their chemo. So I think a lot of questions came out of this, and I'm going to have Dr. Parikh start with this one, because I think we can discuss the fact whether radiation is helpful. If radiation is helpful, which type would you consider? Are there certain patients that you would consider radiation for and others that you wouldn't? So I'm curious as to what you thought about this trial and how it really impacts the way that you think of these patients who we're realizing more and more need neoadjuvant therapy, but do we want to incorporate radiation in those patient populations?
Yeah, so I think, let's sort of set the stage again. It's a borderline trial. And I think for all these patients, this trial was conducted not just sort of at academic sites, high volume centers that do a lot of these surgical resections and have MTDs and things too. So I do think we need to take that as we're into consideration as we're looking at our surgical, R0 resection rates. And what the trial was not designed to do actually was compare head to head. So it took me a little while to wrap my head around this too, but it was sort of this pick the winner, or was not sort of this pick the winner, not head to head, but compared to, a benchmark. And here's what we're going to take forward in our further neoadjuvant trials. So what would be the best regimen to take forward using this 18-month OS mark, which they defined. And they use basically, at 18 months, they had a reference of 63%. They had an interim analysis. And if you didn't hit the interim in terms of how many you were taking to R0 section, in the radiation arm, they declared it sort of as futile. But what's key, I think there's a couple points. One is that this was SBRT and not, long course conventional chemorads. There is some data from the pre-OPANC study, as well as a Korean study with conventional chemorads with gem-based chemotherapy. No really OS benefit, but maybe some kind of local regional control benefit for using conventional chemorads. I think what's also interesting to note here is there was actually a path CR rate with the radiation group too of 11% in this study too. And so I think it wasn't meant to compare the two approaches. It used SBRT, not conventional. And how we make these decisions on an individual patient level in terms of who will actually derive benefit from radiation or not is a really nuanced decision that should be made in sort of a multidisciplinary fashion. I know that's a very vague response, but it's hard to sort of see given in light of other data, and we'll have pre-OPANC 2 coming soon, to say that radiation is dead. And I think that's what was some of the Twitter feeds and things were sort of saying was oh, radiation is dead. And I don't think we have that data from the Alliance study.
I think those are all really good points. And I think, there's a lot still to be discovered and to be discussed on where we go with preoperative therapy for pancreatic cancer. So we have 7 minutes left and we have 2 really good questions. So I want to try to get to them before we run out of time. The first question is going back to the olaparib study. So for patients who progress on maintenance olaparib, would you go back to prior first-line therapy, or would you switch to an alternative second-line therapy? I don't know if anyone has any thoughts on that.
So this is, can you repeat the question? It was.
So for patients who are on maintenance olaparib, would you go back if they progressed while they were on maintenance olaparib? Would you then go back to their first line therapy that they were receiving pre-olaparib, or would you start them on a different regimen in the second line setting if they progress while they're on maintenance therapy with the olaparib?
These patients, in order to get olaparib on the study, they had to have had treatment for at least 4 months, if I'm correct.
It was, 16 weeks, and you had to be platinum sensitive.
Yes.
It's a platinum sensitive disease before you got to go on this. So,
I think it's tough to give more platinum. I mean, most people have toxicities, but sorry, I defer to you guys, but I would be a bit hesitant, I think, unless the patient had no residual toxicities, and there are some.
Yeah, I think you just have to sort of see where you're at, and like it was at least 4 months, right, too, into the study. So like, how much do they actually get beyond? Yeah, so I think it's multifactorial decision, but it's not inconceivable to go back, but more likely than not, you're moving on.
I guess we kind of have to look at it like colon cancer in a way.
Yeah.
Yeah. Or like we can drop the Alsali and then just do 5-FU Onivite and see how how much mileage we can get out of it, and then go to the jam abrosing.
Yeah,
I don't think we know that PARP, like if you progress on PARP, does that make you platinum refractory, right? Like we know platinum sensitivity confers sensitivity to PARP, but I don't think we know the other way around.
Yeah. I don't think it's not for the sensitivity. It's just more of a toxicity, I guess, giving more time, because like after 4 months of Alsali, people are pretty much toast. And then, and I think if it is anything, you got like 1 or 2 months and then they started having neuropathy. And then your next step is jam abrosing, then they can't tolerate the abrosing because of the neuropathy. So it's like a little bit of a chicken and egg,
Yeah, so it's not unreasonable, as everyone's saying. I had some patients that I have given, they had received FOLFIRINOX long time ago, and then they didn't necessarily progress, but they had some neuropathy and whatnot, and they move on a couple extra lines. I have tried modified dose FOLFOX if the neuropathy has subsided to grade 1. But once again, this is cumulative. We know after 10 cycles plus, patients start to develop permanent neuropathy. So that's the challenge. Hopefully, at some point, some wine manufacturers, please develop, neuroprotective drugs so we can keep giving these patients oxaliplatin. That would be the best way to do it. And I think there was one agent that was used, and I think the company just fell apart, and that agent was lost and we couldn't use it. But if anyone there has that option, I encourage to develop that, please.
Patient advocates, right? I think a lot of the neuropathy work is really coming from the advocacy community too, which is fantastic.
Yeah.
They're also doing some natural types of ways to avoid the neuropathy.
Yeah.
So we have a question going back to the gastric G-Junction studies that we talked about. When you give FOLFOX Nivo, do you stop the FOLFOX after 6 to 8 doses and continue the Nivo, or do you drop the Oxali after 6 to 8 cycles and continue 5-FU or capecitabine plus Nivo? So that kind of goes to what you were just talking about with platinum toxicity. So I think you kind of answered the question, but especially with FOLFOX, I've had patients who've received a countless number of FOLFOX cycles. So I'm curious if with the FOLFOX plus immunotherapy, do you stop the FOLFOX, or how do you continue with that regimen?
It depends on like how much residual disease the patients may have. I have some first line trial with the chemo IO. So, FOLFOX, you can't give more than 3 to 4 months. I don't usually give more than 3 to 4 months. And then, so if they still have pretty good disease, then I'll just do 5-FU Nivo. And then, if you don't have that much of a disease and with the COVID and the patient need a break, then you will do like, monthly Nivo, which is reasonable. So it's really depends on how much disease you have left and patient's preference.
Great. And then the last question, I'm going to see if we can get this in the last 2 minutes. In a fit patient with resectable and borderline resectable pancreatic cancer, are you usually recommending pre-op chemo off study? And in resectable patients, when would you go straight to surgery?
So the resectable question, there's actually an alliance trial right now looking at kind of, it's sort of peri-op versus sort of adjuvant. So I think we'll get a question of, we'll get an answer to that. I think it probably varies a lot, but I think more and more, just given the adjuvant FOLFIRINOX data, but then also all the data that has supported total neoadjuvant therapy, at least at our institution, prior to the trial, to even for upfront resectable patients, just because it's sort of easier to get chemotherapy into, and we know that there is a benefit. We'd sort of move to doing kind of total neoadjuvant, even in the upfronts, and then certainly in the borderline and locally advanced. And I think the other, thing with even the locally advanced patients is kind of giving people a shot at the OR, at these highly subspecialized centers where people, CT scans are notorious for, not being great at really getting a sense of what your R0 resection might look like. And so, unless people are actually progressing through giving neoadjuvant therapy, chemo rads, and then giving patients an attempt at resection, even in a locally advanced setting. So,
and I do want to mention SWOG 1505 real quick, just because it was presented and it was published just, I think, last month, led by Syed Ahmed and Devendra Sahal. But looking at the role of neoadjuvant therapy, pick the winner, right? So Gem-Abraxane versus modified FOLFIRINOX, and noting really no difference between the two. So obviously very dependent upon the patient and your discussion with the patient.
So I have to say that we reached our 6:30 mark, and I know that people are actually still here because we've been getting questions up until the very end. So I want to end this panel today by, first of all, thanking our exceptional panelists for really providing us with some really exciting new GI oncology updates. And I think there's a lot to talk about as to what changes Monday morning. And I'm really happy that I was able to be a part of this panel with you, incredible panelists today. So thank you so much for all of your insight and your intelligent commentary on all of these trials. And to everybody else who joined us today, thanks for sticking with us late into the evening on this Friday night. I hope wherever you are, you're staying safe and warm and healthy. And we look forward to engaging with you more over the next couple of months and years as we see more immunotherapy agents, more targeted therapy, and more changes in GI oncology as we see more trials coming down the pipeline. So thank you so much, everyone.